Hello guys, today we're going to be discussing about how to approach a child with fever. We're going to go over the basics of what temperature thermoregulation is, all the way into what fever is, how to approach a child with fever, and how fever is managed. So, starting off with physiological body temperature. The upper normal body temperature is 37.7 degrees Celsius overall, and this will vary according to the child's age, the time of the day, activity level, and phase of the menstrual cycle. Infants and young children usually have a higher temperature than older children and adults because they have a higher body surface area to weight ratio and they also have higher metabolic rates. The temperature is usually lowest in the morning and peaks in the late afternoon. The mean amplitude of variation is zero point 0.5 degrees Celsius. And what's interesting to note is that during a fever or a febrile illness, the low and high temperature variations are maintained, but they are at a higher level, and the variation itself can increase to 1 degree Celsius in those who are recovering from a febrile illness. The hypothalamus is responsible for balancing the heat production and dissipation to maintain a steady body temperature. And once the environmental temperature exceeds 35 degrees Celsius, the body's ability to dissipate heat will be overwhelmed and the core temperature will start to rise. Now, elevated body temperature. This term encompasses two definitions. We have fever and we have hyperthermia. Both are not the same thing. As a matter of fact, they have a completely different pathophysiology and completely different management. So let's start off with fever. So, fever is defined as an abnormal elevation of body temperature that's occurring in response to a specific biological reaction or trigger which happened in the body. And fever is mediated and controlled by the central nervous system. So, what is the difference between fever and hyperthermia? So, fever is when the body temperature increases secondary to an increase in the hypothalamic set point. So we'll be looking at what hypothalamic set point is in the diagram in the next slide. But what's critical to remember is hyperthermia is the other way around. So hyperthermia is when the body temperature increases despite there being a normal hypothalamic set point. So in fever, the high body temperature is following an elevation in the hypothalamic set point, whereas in hyperthermia, the hypothalamic set point stays the same, but the body temperature is what rises secondary to the environmental factors. And as we said, they are completely different conditions, so it's important to distinguish between them as they have different implications, different management strategies. The primary one being that hyperthermia will not respond to an antipyretic agent. And as a matter of fact, it is a rapidly fatal condition. So, see here on the table or on the graph on the left side, you can see that the hypothalamic set point is around 37 degrees Celsius, as marked by the empty circle, and the temperature range is around about that set point. In fever, that same law is respected, but the hypothalamic set point reaches a higher point. Whereas in hyperthermia, you can see that there is a dissociation between the set point and the temperature that the body is maintaining. So the set point is at a normal point, but the body's temperature is much higher. How does fever develop? So if there is an infection or inflammation, this will trigger peripheral synthesis of interleukins, tumor necrosis factor, interferons, and other cytokines from phagocytic cells in the blood and tissues. These cytokines will go over via the blood towards the hypothalamus, where they will cause an abrupt increase in the prostaglandin synthesis, especially prostaglandin E2. So just remember the name of this prostaglandin because it is asked in exams. And the induction of prostaglandin E2 will trigger the hypothalamus to raise the set point for the body temperature. So these prostaglandins affect the hypothalamus and increase the set point for the body temperature. After that, the body temperature will rise to reach the hypothalamic set point. How does the body increase the temperature? It will increase the heat production by increasing the metabolic rate, increasing muscle tone, muscle activity, and reducing the heat loss through diminished perfusion of the skin. So these pyrogenic or fever-inducing cytokines will also increase the synthesis of acute phase reactants in the liver, for example, the CRP. They will decrease the peripheral serum iron and zinc levels. So this is important to know that during the febrile illness or the fever spike, the circulating iron and zinc levels will be low, and we'll see why that's important in the coming slides. Fever will provoke leukocytosis and it will accelerate skeletal muscle proteolysis. Another important clinical distinguishment between fever and hyperthermia is that in fever, the temperature will very rarely go higher than 41 degrees Celsius, whereas in hyperthermia, it's not uncommon that the temperature will cross 41, reaching 42 degrees Celsius or even higher. So let's come to some practical aspects of fever. Now we know what fever is, but how do we measure it? So, clinically, there are a lot of different modalities by which we can measure fever. The gold standard or the most close to the core temperature is the rectal thermometry. So, nowadays we are using a digital rectal thermometer. Previously, glass thermometers were used, but now they are unadvisable because they are difficult to read. They can cause injury if they break, and they can spread infection because they are harder to maintain cleanliness than the digital thermometer. Of course, there will be a lag between the core and the rectal wall temperature, but still it will be the most accurate compared to the other modalities. Rectal thermometry is contraindicated in patients who are immunocompromised, having neutropenia, or those who are having bleeding tendencies or necrotizing enterocolitis. So, the principle behind these contraindications, and these are very critical to remember, is that a neutropenic or immunodeficient patient, while you're inserting the thermometer, you may cause an abrasion there, or the skin may be very unhealthy, or the mucosa. So you're creating an opening for the bacteria to enter the bloodstream and cause an infection. And that infection in an immunocompromised patient can easily become sepsis. In a similar way, someone with a bleeding diathesis might get cut while you're inserting the thermometer, causing profuse bleeding. And in necrotizing enterocolitis, both of these risks are present because the mucosa of the intestine itself is edematous, friable, and weak. So there's a very high chance of bleeding, infection, and even intestinal perforation. Oral thermometry is usually preferred in cooperative children. If you compare oral to rectal, there is a zero point 0.6 degrees Celsius difference. So oral will be 0.6 degrees Celsius lower than the rectal temperature because of mouth breathing and the effect of eating or drinking a hot or cold liquid on the oral temperature. Axillary thermometry is done via the armpit of the child. So this, as you can imagine, is a very peripheral source of temperature measurement. It's very prone to variations and inconsistent conversion between the axillary to the rectal. So it's not very reliable. But if you have a child who's not able to use an oral thermometer or has a contraindication to rectal, then you can go for the axillary temperature measurement. Infrared thermometry is probably the newest out of all of these, and this includes the tympanic thermometry as the most common one used nowadays. So this is also measuring the amount of heat produced by the tympanic membrane, and this is close to the core temperature, depending on the quality of the device. So you can actually get a good result from the tympanic thermometry. Um, Another form of infrared thermometry is the forehead thermometer, or the which is sometimes contact and sometimes non-contact. So there can be a strip kind of thing which is placed on the child's head, which can tell the temperature, or a machine that you just hover over the child's head and it will show you the temperature. So those are less reliable, obviously. So here we can see some examples of the modalities of temperature measurement that we discussed. We can see tympanic, which is infrared, the forehead strip, which is again detecting the heat radiated off the temporal arteries, similar to the forehead infrared, which is usually either contact or non-contact, but both are equally non-reliable. We have the rectal, which is the gold standard, oral, which is usually the easiest in cooperative children, and axillary as well. So the question arises now, should we adjust a non-rectal temperature? Because we said that rectal temperature measurement is the gold standard. But now, does that mean that we need to correct all the other temperatures? For example, if we have measured an oral temperature, should we add zero point 0.6 degrees to write it as what we suspect the core temperature will be? The answer, as per up to date, is no. So you just have to write down the temperature you measured and the modality of checking it. So that itself will give a clear idea to whoever is assessing the patient of how you got this temperature. Now, coming to a clinical definition, and these are from up to date. What is the definition of a fever and what is a fever of concern? So, in any neonate under the age of 3 months, so a neonate means someone who's under the age of 30 days, and an infant is under the from 1 to 3 months of age. So anyone in this age group who has a fever is a fever of concern, and this is defined as a rectal temperature more than or equal to 38 degrees Celsius. As the age gets older, the definition of fever remains the same as more than 38 degrees Celsius, but up till the age of 3 years, fever of concern is when the rectal temperature goes higher than 39. At this point, you could suspect that it may be something more than just a simple viral infection. And you have a lower threshold for temperature when it comes to high risk children. So, in a similar way as the neonate under 3 months of age is a high risk age group, even older children can fall in the same high risk category if they have a condition which predisposes them to a serious infection. For example, an immunodeficient child or someone with sickle cell disease, somebody with an indwelling device like a dialysis catheter, someone who is generally unwell. Is a caregiver report of measured fever valid? The answer is you have to assess the child clinically, and anyone who's measured a rectal temperature more than 38 degrees, this has to be taken as a significant fever. And even if it's a tactile fever, which is what we'll see in the coming slide. So tactile fever means that the parents didn't check the temperature using a thermometer, but they just felt that the child is warm. So both of these things are significant based upon your assessment. You cannot dismiss uh, a child just because he doesn't have fever when you're seeing him now. It may be that the parents have given him paracetamol or given him some other treatment. So you need to assess the child from head to toe, take a detailed history, physical examination, and then decide on whether this child is coming under a low risk or a high risk category. Now, this is an interesting question. Can bundling cause fever? So, what does bundling mean? Bundling is when the baby is wrapped in blankets, and let's say the baby's temperature was checked and it's showing a temperature more than 38 degrees Celsius. So, can it be because of the blankets? The answer is that if the ambient temperature and humidity, which means the temperature and humidity of the surrounding room, if the humidity is less than 75% and the temperature is less than 35%, any baby who's having a rectal temperature more than 38 is not having this high temperature because of the bundling. So again, we come to that high risk age group under the age of 3 months. So you should not attribute that to bundling. And any fever which is more than 38.5 should not be attributed to bundling regardless of the manner the temperature was taken. So if you're having a very well child who's afebrile and had a mild report of fever at home and the parents are unsure of the way they checked it, the temperature of the room was not according to the criteria that we discussed earlier, then you can consider the factor of bundling. but again, you have to follow the child up closely. So we're going to go over a very short case presentation. So this will help us get an understanding of how fever is just a sign. It can be a manifestation of so many different diseases, but we're going to go over one of them. And the point of this case presentation is just to share how cases of fever should be approached on a general level. And the principles standing just follow the basic history and physical examination principles, but there are certain points that you need to look out for. So we have a 1 month old boy who was brought to the emergency with complaint of fever and crying. So what would you like to ask his mother? Already we have a red flag, which is the age of 1 month, and we have a caregiver report of fever. So we need to explore these symptoms in details to elicit the red flags which may be present and which will definitely influence our management. So let's run over this case quickly, and later on you can brainstorm about each of these points which we have asked. But let's just go over this patient's scores. So he's a 1 month old boy born at term. So antenatal history is extremely important if you have a neonate who is presenting with fever. And the importance of this cannot be stressed upon enough because we mentioned that the age under 3 months is a red flag. These are the high risk patients. So we need to make sure that we have a very detailed antenatal history because it may be that this baby is having late onset sepsis. He may be having any kind of issue which would be missed if the antenatal history was not taken into consideration. And he's previously healthy, which is again very important because if this baby had some health issues after he's born, these will increase his risk of having a serious kind of infection. So the onset was one last night, so it's been a few hours. He's been irritable, not interested in feeding, and having a fever. So being irritable, not interested in feeding, these are again red flags. And the parents might not volunteer this information. But as a physician, you need to know that these are very important questions to ask. Now, the temperature was measured between 38 and 38.5. So as a doctor, when you ask the parents, they some of them are more alert than others. Some of them remember the temperature they're checking. They know what time they check. They know how many hours it's been since the fever spikes. But what most of us forget to ask is how you measure the temperature. So let's say the axillary was 38.5. So that means probably the core temperature was higher than that. So in our case, it was a rectal temperature. So we're lucky we have a core temperature measurement and there was no associated shivering or rigor. So it's helping you see the severity of the fever and it's responding to paracetamol. In systemic review, you'll be able to see that there's a huge list of things you need to ask from head to toe, and especially in a neonate, these are of vital importance. And in any child for that matter, if you do an extensive systemic review, that is the only way that you will be able to understand where the infection is, what is the source of the fever. So our patient has been crying excessively and inconsolably. He's not feeding well, he's vomiting, his urine output is less, he's having dark urine, he's having runny nose, he's having cough, but there's no skin rash, there's no seizure, there's no unresponsiveness, no stopping of the breathing, also known as apnea, and no change in the stool. So just by this initial impression, we can tell that this child is not going to be discharged home for sure. He's having a lot of red flags and he needs to be managed more carefully. Sick contact is a very important question. So his sister is having an upper respiratory tract infection, which may help us diagnose what he has, but given his age and his condition, we can't attribute it to a very simple cause. Birth history we already discussed, but again, maternal serology, her vaginal swab, urine result, these are very important in a neonate. And then we'll quickly run over the other points. So he's otherwise not having any previous surgeries or any hospitalization. And he's also vaccinated. Again, this is very important. Maybe not for the neonatal age group, but definitely as the child gets older, you need to know whether he was vaccinated or not. Sign examination, you can see that the child is tachypnic, he's tachycardic, he's having a delayed capillary refill with skin mottling, his ENT is congested, he is having normal heart sounds but tachycardia is there for sure, and CNS examination is showing you a very irritable, inconsolable baby who is having a bulging anterior fontanelle. That history and physical examination, we don't even need to continue seeing the investigations further, but we can tell that this child is very sick. He may be having sepsis, he may be having meningitis, encephalitis. We are not sure. He may be having a urine infection which has spread into sepsis. So, certainly, by a mother bringing a child just with fever, you have managed to clerk the case in such a good way that you are able to elicit his physical examination, historic findings, and even before doing investigations, you have an idea of what you are suspecting. You're not going in blindly and doing a lot of investigations. So, briefly, we can see in this child that he's having an elevated lactic acid, the glucose is low, he's having high white cell count, predominantly neutrophils, he has a high CRP, his urine routine is looking normal, but the cultures are pending. So if you follow this algorithm, which is not the objective of our presentation today, but you will see that this baby is looking like he's having signs of sepsis or meningitis, in which case you will start with antibiotics and you should proceed for a lumbar puncture. So in this baby, he was diagnosed with E. coli meningitis. He completed the antibiotics and he was discharged home. So let's wrap up our presentation now with how to manage fever. So fever, as we said, is a sign. It's not a diagnosis. It's not a disease. So this presentation is not about talking about the treatment of every single cause of fever, rather dealing with the fever itself. So it's really important to remember that fever is an integral part of the inflammatory response to fight infection. Fever in itself is not the bad guy. Fever is the messenger or the flag bearer. He's showing you that there's something happening in the body. What is the benefit of fever? Have any of us ever thought that fever is actually doing something good? So, fever will slow down the pathogen growth and reproduction because, as we mentioned in our at the start of our presentation, it's reducing the circulating iron level. So the bacteria is not, or the virus is not going to grow as easily. The fever will also enhance the immunologic function until a temperature of 40 degrees. If the fever goes higher than 40, then the immune system will not be stimulated as well as it was before. Harms of fever, definitely it is an uncomfortable feeling. The body aches are because of raised prostaglandin E2. The child will be tired and sleepy because of a raise in interleukin 1. And if the child is having any kind of condition which is compromising the cardiopulmonary reserve, as we'll see in the coming slides, this child can become very sick because of the fever itself, as fever will increase the metabolic demands on the body. So, in these kids, fever is actually a problem or a serious thing which needs to be eliminated. So remember this, this is basically the core slide of this entire presentation. So fever is an important clinical sign. Fever is not an illness, but it's a physiological response. The first step in management of fever is to determine the cause. Once you know the cause, the main reason to treat the fever itself is to improve the child's condition. This is for a normal child. And in otherwise healthy children, the fever will be self-limited. It will be benign, and once the cause is treated, then the fever will disappear by itself. So all you need to do during the febrile phase is make sure that the child is well hydrated, because we know that fever will increase the insensible fluid losses. Fever does not cause brain damage or make illness, the underlying illness, worse, like is a lot of traditional beliefs. So again, this is repeating the same point. So routine treatment of fever in an otherwise healthy child is not warranted. There is no evidence that reducing the fever will reduce the morbidity or the mortality from the underlying illness, except for the children who are having limited reserves for increased metabolic demand. And we will see examples of those kids in the coming slide. The benefit of treating fever is obvious. You will improve the discomfort, you will reduce the insensible water loss. There will be some pain relief if you're giving paracetamol, ibuprofen, for example. But the harm is that you may delay the identification of underlying illness, and there can be drug toxicity. So we'll discuss both of these points in the coming slides, but very briefly mentioned, how does giving paracetamol, for example, delay the identification of illness? The child is still ill, right? The point is that if, for example, it's a small baby under 3 months old, and the parents are giving paracetamol for fever, that's a fatal mistake rather than bringing the child to the hospital. Because in such a small age group, or let's say it's a child with cancer, and the parents found that he has fever, and they're not very well educated about his condition, so they give him paracetamol at home. Do you think that the paracetamol is treating whatever is causing the fever in the first place, especially in kids who are weak, you can say, or not having an immune reserve as good as that, or a child who's having a heart problem and having a high fever? So these are critical mistakes which can result in a very big disaster for the patient. So something which started off in the early phase with just a fever and some mild symptoms will eventually turn into a huge monster with the child, which the child will present with. So treating fever, uh, you know, with eyes closed in all children is not the right decision. And drug toxicity happens because, let's say you have a patient with a simple flu, and the parents are giving him paracetamol every 4 hours, and they're also giving him a medicine, a syrup for the flu. Little do they know that the flu medicine can sometimes contain paracetamol inside it, or ibuprofen inside it, but paracetamol is more common. So you're giving paracetamol every 4 hours, and without realizing, you're giving the flu medication once or twice in the day. So the child will go into a paracetamol overdose. So you have created a condition in the child which is far more serious than the simple viral infection that he had. Let's come to the indications for treatment of fever. Like we said, anyone who cannot tolerate the increase in metabolic demand. So someone with shock, underlying neurologic cardiopulmonary disease, alteration in fluid and electrolyte balance, high fever more than 40 degrees, if the child is very uncomfortable, if there is a major head trauma and post cardiac arrest. Now, antipyretic agents, usually you're choosing acetaminophen. It's the first line recommended drug because of its long track record of safety. Again, it should not be used independently by the parents in babies younger than 3 months. The onset of paracetamol is within 30 minutes to 1 hour, and the duration is from 4 to 6 hours. There is no proven association between acetaminophen and asthma exacerbation, but remember that overdose of acetaminophen can be lethal, and especially in the community, it happens when it's accidentally given in combination with cough and cold remedies. So people don't realize that they are giving an excessive amount of acetaminophen. Ibuprofen is stronger than paracetamol, and it should again not be given in any baby younger than 3 months. As a matter of fact, ibuprofen should not be given to anyone who's younger than 6 months of age because they are at high risk for kidney damage. So, if you're ever giving ibuprofen, which again, it's not as good, it's not as safe as paracetamol, you have to make sure that the child is very well hydrated. Common side effects of ibuprofen are tummy problems like gastritis, GI bleeding, and acute kidney injury, including, inappropriate doses. So the duration of ibuprofen is longer than that of paracetamol, lasting around 6 to 8 hours. And overdose can again occur in the same way as it occurred with paracetamol. Can we give combination of paracetamol and ibuprofen? You should never give them at the same time. In clinical practice, there is the tradition of if the child has a very high fever, which is not responding to the antipyretics, you can alternate between ibuprofen and paracetamol. So keeping the spacing of paracetamol to paracetamol every 4 hours and ibuprofen to ibuprofen every 6 to 8 hours in case the fever is not coming down with paracetamol. But there's a lot of things to keep in mind. You have to make sure that the parents are understanding very well how exactly this alternating therapy works, and to avoid confusion, inaccurate dosing, and again, both should not be administered simultaneously. So the current recommendation as per up to date is just to start with ibuprofen, and if it's not getting better, then shift to just to start with paracetamol and change to ibuprofen if it's not getting better, or if you started with ibuprofen, then change to paracetamol. But again, if the fever is not coming down, the child is sick and he's getting sicker. This doesn't mean that the problem is in the antipyretic you're giving. The problem is inside the child itself. There's something serious going on, so he needs to be reassessed. External cooling, which is I think one of the most common family remedies for fever. So it's not recommended alone if the child has a high fever, and that goes back to the pathophysiology. So if you're just doing external cooling, remember that in fever the hypothalamic set point was higher. So the problem was the hypothalamic set point. The body just followed that hypothalamic set point. So even if you're using sponges and cooling the child, the body itself will try to make the fever come again because it's following the set point. So the best way is if you want to do external cooling, you should give an antipyretic at least 30 minutes before so that the set point comes down, and then you can start the tepid sponging. So it should be done with warm water. You shouldn't use freezing cold water. Just use lukewarm water, and the evaporation will help the heat loss. Back in the day, they used to use alcohol as well, but that is not recommended at all anymore because the fumes will be absorbed by the lung and it can result in CNS toxicity. And you will see in hospitals or in the ICU, a lot of children might require a cooling blanket. So especially those with a head injury. In a later presentation, we can discuss about that. But cooling is part of their treatment. So a cooling blanket is also something which can be used in a hospital setting. Duration of fever treatment, we know the guiding principle is just comfort in a healthy child. So you don't need to keep giving antipyretic in fever because most of them are of viral origin, and if the child is getting better, the fever will get better by itself. And as we said, you have to reevaluate if the child is not getting better, having higher spikes of fever, or having new symptoms and signs. So, in conclusion, we discussed all these points already, but fever is an abnormal increase in the body temperature resulting from elevation in hypothalamic set point. You should find the cause of the fever, especially in someone aged younger than 3 months or an immunocompromised patient, and you will decide about the treatment of fever based on from one patient to the other. Thank you so much, guys. Hope that this was a good presentation, and see you all next time.